Our conversation for this hour is around caregiving and the realities of caregiving, an industry that is growing quite rapidly in the country, but that has been a staple, of the West. And the fact that we have very well-trained Kenyans who move abroad to do caregiving work has been very well known. But now, internally as well, Kenyans are doing amazing caregiving work. But want to get into it, understand what the industry looks like, what the need for it is, of course, what it means on a day-to-day basis for a caregiver. Doreen Nkatha is one such caregiver. Good morning, Doreen.
Morning to you.
It's so good to have you.
Thank you for having me.
Tunaanzanga with the quote of the day. We usually have a quote and you can say if it speaks to you, if you agree or disagree with our quote, okay?
Okay.
Today's quote is by Bessie Head and it says, "There's always someone holding the ball. If you look over your shoulder, you will find people with hearts more generous than yours." There's always someone holding the ball. If you look over your shoulder, you will find people with hearts more generous than yours.
It's very true.
Mm-hmm.
Yeah, I agree.
You agree?
Yes.
Yeah. Do you think there's someone with a heart more generous than yours, Kweli, Doreen?
Yeah. Sometimes.
Sometimes.
Yeah.
Okay. I get that. I think when someone hears a caregiver, just like this, any kazi ya kujitolea. And it's such important work. It requires a huge amount of empathy, of kindness, a high level of skill and training. So it's like, anyway, who has a heart more generous than yours, Doreen? But talk to us about how you got into caregiving work.
Okay. Basically, I trained as a registered nurse, of which I worked in hospitals, so many hospitals. And then eventually, when you're looking for a job and you're not finding it, you also have the skills. You can be a caregiver, and an opportunity comes by. You grab the opportunity and you go for it. So basically, I started caregiving after training as a critical care
nurse.
Yes, as a critical care nurse. That's when I started the caregiving. Mostly you are very sick patients. Sometimes they are in the ward and the cost is very expensive for them. So there are so many companies offering the critical care nurse, the home care. So someone approached me. She was a colleague we were working with at that time, and she had opened a home care. And she was like, "Doreen, you've done a critical care nursing, and I have a critical patient who needs a home care. So are you available?" And I was, okay. That time I was working, but I could chip in for her and assess the patient. So currently she was having basic nurses, and the patient was very sick. The patient needed a critical care nurse. So it was during the night and I chipped in. I assessed the patient. The patient was quite sick. And I assisted the other nurses. I worked with the other nurses who were caring for the patients. And then I felt like, no, this industry needs critical care nurses because these patients cannot be managed as well by a critical care nurse the same way they are being managed by a basic nurse. So that's when we started the critical care nursing as a home care. Yes.
You know, we've heard of these home cares, but abroad.
Yes.
So we hear of Kenyans who've gone to work in the UK, in Europe, in America, who've been involved in this industry called home care.
Yeah.
In Kenya, how we've known home care, mtu ameenda hospitali, anakuwa discharged, anarudi nyumbani. Somebody in the home takes care of the patient. It's a joint effort, but there's somebody who's taking lead, right?
Yeah.
So somebody at home will take lead in just taking care of the patient. Kama ni kidonda, kumuosha, feeding the patient, and so on and so forth. But they have an appointment with the hospital to take the patient to the hospital for clinics. Okay?
Yeah.
Now, in comes this industry that is thriving and growing in Kenya called home care.
Yes.
How different is it from how we know how to take care of our relatives who are sick? What's the difference?
There is a big difference because relatively the patient you has been discharged, the one you know about, the one you're talking about,
Yes.
that's a patient who is stable enough to stay at home. And the things that they are doing at that time are basic needs that anyone can do.
Could change a bandage.
Yeah,
or
could change
Helping them
kidonda,
to
bandage, kumfeed.
Take a bath.
Yeah, those are just general things that anyone can do. But now comes the one that we are doing now, the critical care. These are sick patients, a very sick patient who cannot be taken care by a relative. The patient needs things like sanctioning. A relative cannot do that.
Sanctioning.
Sanctioning is when the chest is congested, and you need to remove that
Mucus,
yes, from the chest. So a normal person cannot do that.
Yeah.
The patient, sometimes the patient needs oxygen. A normal person cannot know how much oxygen do I need to give to this person. As very sick patient, a normal person who has not been trained will not know how critical is this patient. Does this patient needs to go back to hospital? Does this patient needs more tests, blood tests, x-rays, MRI? Does this patient needs more care than? But you see, when it's a relative who is managing the patient will die eventually if they are doing the care because they don't know what to do. They will not be able to note when the condition is changing. Unlike a critical care nurse or a general nurse who can notice this patient is not doing well, we need to go back to the hospital.
Okay.
Not generally the normal clinics for the hospital.
Lakini Doreen,
Yes.
why is this patient not in hospital?
I was just about to ask.
Yes.
That sounds like, it's a critical. Huyo mtu anafaa kuwa hospitali.
No, okay, this person is not in the hospital. Number one, you go in hospital, you'll find me there. Okay? I'll be the one taking care of this person. The same way at home, I'm the one taking care of this person.
Yes.
The difference is when we take a patient home, we organize a room just like a hospital. We do all now the cost goes to the relatives. They have to be at least financially stable, of which the home care is much cheaper than the hospital.
Is it?
It is very cheap.
Higher.
In a hospital, for a critical care patient who is admitted in an hospital, first of all, the admission fee the deposit for most hospitals, it's more than 300,000. That is deposit. You've not even started taking care of this patient. Now comes us. If a relative, they can buy everything that is needed for this patient to be taken care of at home. It is the same because you buy everything you need. You buy if it's an ICU bed, you buy all the oxygen you need. You buy the concentrator. The concentrator it's preferable than the oxygen because it will use the room air. Then you buy a backup oxygen cylinder. You buy everything that we use in the hospital. You buy them at home, and you set that room like an hospital room. So I'm there full time. Unlike the ward, you have like 5 patients. I'm not there full time for that patient.
Right.
So if it is the ward, I'll be looking after maybe 3 patients or 5 patients. For an ICU, you go to 2 patients maximum. But here at home, I'm there full time. I'm just seated next to the patient. So in case the condition changes, this patient gets the best care. Unlike the hospital, when sometimes the condition can change and you're helping another patient, you'll not notice. And even when you're noticing, sometimes it's a bit too late. Unlike at home, where I'm there full time, 24 hours, I can stay with the patient, I can assess the patient, and then they will loosen the burden for the relatives, because now ICU, let's say in ICU, you get to pay, the least you can pay in a day, it's more than 200K in a day. At home, the relatives only gets to pay me.
So we are removing several other, because the hospital you're paying overheads for the hospital. Here you're bringing, and the overheads will be lower.
Yes.
Okay. And you've brought the patient home.
Yes.
I get where that is going. I do. Do you?
I get where it's going, and I understand the need for it. It's only the thing I'm actually stuck at is that it's cheaper, because in my head I thought at home care like this is for the wealthy, because it's more expensive than being in a hospital. So that's where I'm actually
especially if you
stuck
bring
at.
if you all those things that for example she said, Doreen is saying, you'll buy a bed, you'll
An
buy
ICU bed, not a bed.
ICU bed, you'll buy the concentrator, you'll buy standby oxygen, you will buy all these things. I'll have to buy the reusables that you're using.
Yes.
I'll have to buy all those things.
And the
That's
supplies,
cost.
yes.
But you see,
Sounds expensive,
you will still
Doreen.
pay for those things instead of just minus buying a bed in a hospital.
Yes.
So the question would be, can I hire an ICU bed
Yes.
instead of having to buy? Because then that would be like, okay, so you can basically, there's another, inside of the industry, or maybe it's the same industry that you're in, that is now coming in with offering these services.
Yeah.
Yes.
So you'll hire a bed. It'll be at a lower fee than if you went to
Buy one.
buying one.
Yeah.
It'll also be cheaper than if you went to a public first hospital, because now we're going with public hospital.
Yeah.
Will it be cheaper for me to hire this bed, to the daily rate for the bed in a public hospital versus from these guys who are offering me? Will it be cheaper? You're saying overall the cost is gonna be lower.
It is very low. We also, as Danka Home Care, we have our equipments, whereby if we get a patient, they can hire. They can hire a concentrator, they can hire an hospital bed, an ICU bed, an oxygen cylinder, all the things that we need for that patient.
Right.
They do hire.
So it doesn't have to be bought.
They doesn't have to buy.
Okay.
Yeah.
Let me speak to essentially the advantages, and you've spoken to that 24-hour care that someone is able to get when they're at home.
Yeah.
Speak to me about the other advantages of doing this at home as opposed to in a hospital.
Okay, at home, there are so many advantages for the patient, especially. For example, you have a young mother who is sick. Our patient is a young mother. Currently, like our current patient is a young mother who has kids, young kids. Sometimes you find maybe you have an operation and it goes wrong, and you're confided in a bed for months. So we advise, it's good to go back home, have a home care. You are able to get close to your people. When you're having your loved ones near you, the healing is also better.
From
For
a psychological
healing for the patient, emotional healing. Unlike in the hospital, whereby if you're sick, we don't allow kids in the hospital. Like we don't allow below 12 years to visit the wards. So if it's a mother, it means for the duration they'll be in hospital, they'll not be able to see their children. For the relatives, some are far. Let's say you're in Nairobi, you're in an hospital in Nairobi, and your relatives are in Marsabit, Moyale, Narok. You need time to travel. Then you can't visit them every day. You can't travel every other day. In an hospital, there are hours for visiting. You've traveled the whole night, and you'll only get less than 5 minutes with your patient. So you find that there's they're not together. And apart your time with the patient, and then they also miss the patient. Home is always the best. Even when you're sick, even if it's a day you're in a hospital, you'll always prefer to be at home.
It's true.
And now we have the Danka home care, which is bringing you to your relatives. Your people can come visit you at any time. They don't have to travel, because we bring you to your house. We set a hospital in your house. We have all the people that you need. If it's a physiotherapist, we have one coming. If it's a consultant, an intensivist, we have one coming to revisit. If it's someone for the lab, we have someone who can come and take the labs and do the lab works. If we need a CT scan, it is easier to commute. We just take the CT scan and bring you back home. So you're closer with your people. You're closer with your children. You're closer with your spouse. You're closer with your father, your mother, your friends. And then you also feel the need to get well fast. Because you feel like, no, I need to be well for these people. Right. They are caring too much. So I need that, I need faster healing. Of it in the hospital, you find you are alone. Most of the time, as the caregivers in the hospital, we don't have that much time to be there, seated with you throughout. We don't have that time. Because we have other things to do within the hospital and for other patients. But here at home, you're with everyone that you need. You will stay with your people, unlike the hospital where you can stay for hours alone. It's the only time you get to meet someone, it's during visiting hours, which is less than 30 minutes.
Right.
Depending on the time they'll come to see you.
There's the other now side that I was thinking about, which is what happens when things escalate at home. Because essentially when you're in a hospital, you have access to emergency services, you have theaters, you have... better.
A doctor
Yes.
is on call and standby,
Yes.
and there will be maybe a doctor in the facility.
Yes.
Things just go awry at any one time. You need to have like an ambulance on standby right there, and so on and so forth.
Yeah, most of the time. That's why we are trained. That's why the difference comes now between someone who is not trained and the trained ones. We can tell when the patient is not doing well. And it's not like instantly the person changes the condition. It's not that way. It doesn't happen that way. Because this is already a patient. This is your patient. You've been taking care of the patient for some time. So you can tell the patient is not doing well. Like in our current situation, our patient is already in the hospital because the patient needed more care, theater, to go for an operation. So we monitor the patient. We have our doctors also. We have our consultants. We have our intensivists. We consult them at any given time. When the patient changes condition, we call them. They come to review the patient. Hapo tu kwa nyumba.
Now, I think I can see, I see the sense of what you're saying. And, there's... In other parts of the world, this is a well-developed industry. My issue is, and I'd like to understand maybe with some numbers, is whether Kenya is getting to that level of actually getting to understand and see the need for home-based care for patients. And the cost issue of the home-based care. Right? Is it because it's an industry that obviously needs to grow, to develop in this country. Is it developing at a pace that it should be developing? It's an attitude issue. Largely, do people actually feel that if you remove this patient from a hospital and then you bring them at home, alafu ukamwandikia nurse, you are sort of giving them, a lower level of care than they would be getting if they were in a hospital? Is the mindset of the Kenyan shifting as fast as you guys are developing?
Right.
Let's discuss that after the break. And also to get to understand, so this industry, who takes care of the caregivers even? So you're a nurse, you're trained, even as you're in your training, how are you trained to take care of yourself and to get care? Doreen Nkatha is a caregiver. She's a trained critical care nurse. She works in the home-based caregiving sector, which is growing. Have you ever heard of such? Do you know of patients who are actually receiving home-based care from specialists like Doreen? How is it like? What's the community saying around it? Are they saying, wale watu wako na pesa? Wako mpaka na kitanda, wamejijengea hospitali kwa nyumba. I mean, what's the attitude of the Kenyans on this? We'll be back shortly after this. Kabisa. So we're talking about, caregiving and particularly home-based care. Do you know about that? When you have a patient who needs a nurse throughout, and then the patient comes home from hospital, and you get a nurse to come and work with them, a medic to come and be with them, right? There'll be a doctor on call. There's a nurse who's there with them 24/7. Does the nurse have to be 24/7, and so on and so forth? But the patient is at home.
Right.
You're not going to visit them in the hospital. They're actually there with you at home. Is it better? Is it not as good? Are Kenyans accepting that is actually a possibility of things that could happen? Has the medical profession in this country also accepted that? Because that's the other thing. Have the doctors accepted that, we can send patients home and we'll be going to see them at home? Is the entire system ready for this? Actually, apparently it's been happening for long in very many cases, because like Mohe Azafi says, it's been around for a while, for over 20 years. An average private room is 7K. It's a very big industry in Kenya. Right? Okay.
Okay, 7K, that's in a hospital?
I wonder, Mohe.
Okay.
So what's an average private room? What are we talking about? Are we saying that, there are some people who have set up their own facilities where they're doing care? It's not a hospital. It's not a home. It's a facility that you go to. Or are we talking about setting up an average will cost you 7,000 shillings?
That's a really good question. Yeah, tuambie Muhia.
Muhia, give us the details. But Doreen Nkatha is in this industry. She is a trained ICU nurse, right?
Yes.
She's an ICU nurse is an advanced level of training because this is critical care. And now she is in the home care industry, and she's been giving us that, the journey of that and the experience of it. And Doreen, just before we took the break, I asked you, from what you see and engaging with, citizens, are people ready for this? When you tell your own relatives that nakuanga na patients, naenda kuona kwa nyumba zao, nalala huko, huyo mgonjwa naenda nini. When you tell your relatives that, do they think, lakini Doreen, wewe ulifanya nursing, sasa unafanya nini kwa nyumba za watu? What's the attitude?
The attitude is not good, actually, because it's like they tend to think you're going to be a house manager. You're doing their house girl work. They are like, how can you do that? How can you stay in someone else's house and sleep with them the whole night and not go at home? Yet you trained as a nurse. You should be working in a hospital. Actually, my mom was like, no, you can't do that. I've paid you school fees. You should be in an hospital. But I was like, no, these people, they need also the same work we are doing in an hospital, we extend it here. But it also needs heart. You need to be kind. You need to be humble, because it is not easy living with people who are not your relatives. Bearing in mind your relatives are not easy to live with also. Already. And these are not your relatives. So you find it's quite hard. Sometimes you need to pray, actually. You need to ask for grace to deal with rude relatives. Sometimes even the patient, they feel like they are paying you too much. Like you should not even sit down. You should be there with them. Sometimes even when you're going to the washroom, they don't want you to leave. They want you to be there like throughout. So the perspective is not good at all.
We are yet to understand it. We are yet to understand what this is. Right? This home-based care. I see one thing that you've actually raised here. There is a power dynamic shift. In a hospital, you are under the care of the medics there.
Yes.
So the nurses, the doctors, everybody, even the cleaner have the power. and you sort of feel that the power is with them.
Yeah.
Now you have come to my home.
Yes.
And I am paying you directly to take care of me.
Yes.
The power now shifts to the family, right?
But-
Yeah.
And now they're exercising it. Now, of course, there'll be family members who have different levels of understanding and of the work that you're here to do.
Yes. Yes.
The patient themselves,
Yes.
they may have different levels of understanding of the work that you're here to do.
Yeah.
How do you deal with that?
Okay, sometimes before we discharge you from the ward, before we take you home, we have to come and see the patient in the hospital. Before we even come home,
Right.
we explain to you. And then you find that most hospitals, especially the private hospital, they have embraced the home care thing. Because sometimes the patient, it's a long term, it's a palliative care. The healing could take 5 years, 2 years. Most hospitals, they have embraced it is like a culture now in some hospitals. They advise you. Most of the hospitals I've worked with, actually, they are the doctors themselves. They advise their relatives. The stage that we are in now, you need to look for a home care because your healing will take time. Being in an hospital, you're prone to so many things. You're prone to hospital-acquired infections, unlike at home, where you're being handled by one nurse. You don't have so many medics coming around in your bed. And hospital-acquired infections are spread by medical personnel.
Actually, I did not know that.
Yeah, most
Wow.
infections are spread by medical
I
personnel.
did not know that. Okay.
Because you're moving from one patient
to
to
another.
another. So every time there is an infection, an hospital-acquired infection, this patient will be here for months, for years. You can put this patient at a risk because their immunity is already down because of the disease process.
Yes.
And now there's another infection that comes along, the hospital-acquired, the nosocomial infection. If the patient gets the infection, mostly they will not make it. And even when they make it, the healing becomes slower because they have another illness that is they are struggling with already.
Right.
So in an hospital, you find one medical personnel comes here, a cleaner will still be in contact with the patient. Other nurses, students, they are all coming around. So mostly they are holding your bed. That's how you spread the infections. They're examining the patient. We do keep hygiene and sterility, but sometimes it goes without saying.
Yeah.
You find yourself, the patient, definitely. Most of them, a long-stay patient in the hospital will get an infection. That is most common in hospitals.
Right.
So you find at home, you're not being, even at home, although it's a home care at home, we don't allow so many visitors. Just as in the hospital. It's only that you can visit your relative, for those that are not close, at any time. But even the close relatives, we don't allow them to stay with the patient for long.
Okay.
And before they enter that room, we make sure there's a sanitizer, there's a mask, before they even get into contact with even if it's their spouse. We make sure they have well sterilized themselves before getting in contact. So you find at home, there is no hospital-acquired infections. The patient will heal the ones that she has or he has already without acquiring others.
Okay.
Yeah.
Eric had mentioned this over the break, and we've talked about the advantages to the patient for doing home-based care. Now let's flip it on the other side for family and friends. Advantages and disadvantages of home-based care. Yeah.
For the family.
Yes, for
friends.
the family and friends. But let's say family especially, because they're the ones who will be living with this person.
Family, the disadvantage is that this person needs a lot of money. Financial constraints. Sometimes maybe it's your child. The bill goes high and high. unlike in hospitals also where it is overboard, but you see in the hospital it comes as accumulative.
Yes.
But here in home care, because we don't want to accumulate the bill, we agree on weekly payments or monthly payments at least. But the disadvantage is the relatives are not able to buy the hospital beds or an ICU bed for that matter. We advise on hiring, but if this patient is a long stay patient, like you can assess a patient and know that maybe mtakaa naye for more than 2 years or even 5 years. So if you are hiring for 5 years, that's a lot of money. So you need to come with a solution of buying your own equipment.
Right.
Because when you buy your own equipment, at least you get your cost inakuondokea. Unabaki tu, the cost that you need is paying the nurses, the physiotherapist,
And the consumables.
And the consumables. And like in the hospital where they are a bit exaggerated, you say that you get to buy your consumables as a relative, as you, as the person. So you can bargain when you go to buy as relatives. Another thing I see common.
But just before you go to the other disadvantage, walk me through kitu kama gloves. How much would they be charged in a hospital versus ukijinunulia? Just a basic thing.
Let's say a packet, just a small packet of a glove. In an hospital, it's 1,000. Ukijinunulia, it's 450 shillings. And you're buying in bulk. You can buy a whole box of 10 packets, which unlike in the hospital.
So,
yes. And in the hospital, they go fast. You see, the cleaner is using those gloves.
Everybody who enters this room,
everyone who enters that room will use those gloves. So they fly.
and there'll be many people entering the room.
Very many people in a day. Yeah.
Okay.
right. So you were saying the other thing that you see?
The other disadvantage for the patient, I would say sometimes they are not financially stable, and you have to call upon the other relatives. You see, the relatives makes the decision for the patient, ignoring our advice. Because sometimes we see the best. For us, we focus on the patient. We don't focus on the relatives. You know, the relatives, we just tell them what is necessary. But for us, our interest, we become the patient advocate.
Yeah.
So, because they are the ones who are contributing the money, they tend to contribute on their own, with their own motives. Yes, they want to help, but on their own,
in their own time, at their volition, wakijisikia in short.
Wakijisikia, and then they want to make what is not best for the patient. They want to, they make a decision depending with their pocket, not their. Like for example, we had a patient a long time, and the patient had a terminal illness. Of course, the disease process, the prognosis is not good. And we advise the patient, the relatives, please do not take this patient for herbal medication, because we are already on these other
conventional
drugs.
medicine.
Yeah. Please avoid. But they wouldn't listen.
Wanamuongezea tu mitishamba.
Wana order our medications, wanaleta mtu another person to give mitishamba. And we explain, but what can you do? We leave them, the decision actually belongs to them.
Yeah.
But you see the relatives, the close, the children, they don't want that. But they have no voice.
Because they are not the ones
Because
paying.
they are not the ones who are paying.
Okay. So there are all those dynamics that happen there. You are talking about now the other, are you done with the disadvantages? Let's go to the positives.
Yeah.
What are the positives of actually doing this?
The positives, like we basically said, the positives are more for the patient than even for anyone
else.
than even for us as caregivers. The patient is at a more advantage because number one, the healing is good. The healing is like we had a patient, as I was saying, the hospital, they had given her 2 weeks to live. And this patient comes home. Yeah, she has her daughters, her siblings, her parents. Everyone comes around. And the 2 weeks turns into years. She's still alive.
How many years has it been?
Around 3 years.
Amazing.
And what are we crediting this to?
Home care.
How?
Yeah, because the hospital discharges you and they talk to the relatives. Like, you see, your mom is not going to make up to 2 weeks, the next 2 weeks. We are discharging you. Basically, for them, it was a new idea for the relatives, actually. They had never heard about a home care where a person can go with a vent. It's an ICU patient. So we had to move with the vent. They had to hire the ICU bed, the vent, the concentrator, the oxygen. We always have all those. And even the substitutes ones, the standby. So they embraced the idea. And because the hospital also encouraged, you can get a home care. It will be cheaper for you because the family didn't have the money.
Right.
So we took the patient as a home care, but they had back at the back of their mind, they had been told it's 2 weeks. So they knew within 2 weeks we'll be preparing for burial. But here comes the patient. We assess the patient as critical care nurses. And within those 2 weeks, we had already extubated the patient. The patient had come in a vent, you see, the machine. Within 2 weeks, she was out of the machine.
So breathing on her own.
Breathing on her own, even without the oxygen. With the care of the daughters, the parents, the relatives, she embraced, she wanted now to live again. In an hospital, you know, the patient can hear what you're saying about them. It's true they're in a coma,
They can hear.
but hearing is the last thing they lose. So they can hear, like they're saying, I'm going to live for only 2 weeks. So it's like she's already, she can talk, or he can talk, but he knows I'm going to live for 2 weeks. But now she comes at home, or he comes at home, the love, the need to live. The daughters, they are saying, Mom, you're going to live. Mom, you're going to make it. Everyone is like, no, you're going to make it. Please wake up for us. And you see, she was not talking. She was in a coma, actually.
Yeah.
But within 2 weeks, we have extubated. At home, actually, we have the best physiotherapists, unlike in the hospitals. In the hospital, a physiotherapist has around all the wards to see the patients. There is no way they will give you the best care, because akitoka kwa huyu amepigiwa simu, there's another patient who needs chest therapy. But at home, we get the physiotherapist with us. So even the movement of the muscles, when in the hospital, by the way, once a patient stays for long in an hospital, because they don't have that good massage and the range of motions, movement, they tend to, the muscles weaken. And awakening those muscles after a long time, it's
Nikazi pia.
Nikazi. But you see at home, the earlier you discharge your patient from the ward, the better. Because at home, you get the best physiotherapy for the muscles. So you find that your muscles will awaken faster than in the hospital. Then the healing becomes better.
Okay.
Yes.
Now let me turn the camera onto you. It's already been on you, but now onto you.
Yeah.
This is work that is, of course, demanding physically, mentally, emotionally. It takes a lot out of you.
Yes.
And unlike in a hospital where you're seeing so many people in a day, for you, you're spending the entire day with someone. You're getting to know them, and not just them, their families as well, and their friends, and their community, and their lives, and their homes. You inevitably, as a human being, you bond. How do you deal emotionally with everything that comes at you at being a home caregiver?
Yeah, actually you bond, unlike in the hospital where every shift you have a different patient, which is much better for us as caregivers in a hospital, because you get to deal with a different patient. You don't know their culture, you don't know what their family perspectives. So you deal with the patient per day, and the next day you have no issue with that patient. You are on to another. But here comes even the patient. You become like a confidant when the relatives are not around. Wanakupea ile mushene.
Ile moto.
Ya family. Unaona huyu.
Yeah.
Kuja hapa ananichekesha hapa.
Yeah. Ambia usimwambie what I'm going through. Usimwambie niko na shida gani. Please don't talk about me. So you become more professional. So you don't go get rid of your ethics as a professional.
Yes.
There are boundaries. At times, yes, you listen, but what keeps us from bonding too much is we don't speak about ourselves. We don't, yes, ni mushene, but it's about...
Unapewa mushesha upeani.
Yeah. It's not a two-way, it's a one-way. So when it's a one-way, you advise. You become like a counselor for them, because you know what they are going through. Some they don't. Some, at times they ask you, will I make it? Do you think I'm going to walk again? Do you think I'm going to go back to my former life? So you become like a counselor to them. Definitely you will bond, but you bond professionally. Because sometimes you bond when you give a two-way. When you're sharing your issues and they're giving you theirs, that's when you bond. But
hata mimi mzee wangu anakuanga hivi, by the way.
Yeah.
Hata yeye unisumbua.
Yeah. Because they are saying you like, if I'm well, huyu naenda kumwacha.
Okay. I like that. I hope you also get some form of psychosocial support when you need it.
Yeah, actually, for us, we work as a team. Especially with the Danka. I don't know about other, but with the Danka home care, we work as a team. We work as a team of the physiotherapy. We are close. We are close with the CEO of the Danka. So we share our own.
You're each other's therapists.
We are each other's therapists.
Okay.
So when the patient offloads their baggage to you, you offload.
Inaenda hivyo chain.
Yeah, you offload to your colleagues. It's a way of healing. We encourage each other. Yeah. We talk about it. It's we do well, and we go back. It's like it's about the patient.
I like that.
Yeah.
Thank you so much.
Doreen, thank you for sharing your story with us. And I think it's good to start opening this conversation on what are the possibilities of offering care to patients in this country. Is home-based care one of those structures that we as a community and society need to start thinking about, in a major way? One of the things that, as you're talking about, I was thinking of is you need to decongest hospitals. We always talk about, I needed an ICU bed, but there was no ICU bed available, so we had to travel I don't know how many kilometers looking for an ICU. But if a patient can actually move out of this HDU ICU bed and get it at home, then you're freeing it to an accident or an emergency patient who may need that emergency ICU at that particular point.
Yeah.
So it's a thing that maybe our health system needs to think of and open and broaden that conversation into, do we start embracing home-based care more? We'll bring in Dr. Umo Luga for that one to ask him about it. Doreen Nkatha is a caregiver. She's a trained critical care nurse. She's been talking to us about the motions of a caregiver's reality. In the next hour, we talk politics. The youth. Are you willing to be in the ballot next year as a candidate? What do you need to do? There's a group that's been working on youth. We'll hear from one of them in the next hour.